of today's session will be on the economic and health crises that have been triggered by the pandemic. What are feminist alternatives that have surfaced to address these crises, and what are the challenges and opportunities for achieving a feminist economy? And in today's conversation, we will be unpacking elements of the health response and what needs to be done from a structural perspective in order to really deal with the negative effects that the COVID-19 pandemic has had. I think in the last few months, public discourse has, on the one hand, featured a lot of discussion, especially from the beginning, on the health responses and social distancing and all the measures that needed to be taken. But the discussion on health has kind of fallen away in favor of discussion of the economics. So how do we save the economy? What is the balance between saving lives and saving economic livelihoods? So the real nitty-gritties of how the health sector has responded, how it should respond, what are the short-term, medium-term, and long-term interventions that need to be made, and in particular, who is responsible for making these interventions? Who are the people that are at the cold face of responding to the health crisis that COVID-19 pandemic has exposed? That hasn't really featured in our most prominent public discourse. And so today we'll be just unpacking that. So I will just remind everybody of house rules, and then I will make a brief introduction, allowing the speakers to also introduce themselves and talk about their work. The house rules, of course, is that this webinar has the capability for people to input questions into the chat. So if you look at the bottom of your screens, there's a chat function for any questions that come up, but also there's a Q&A function for specific questions. We'd just like everybody to actively participate and ask questions. If you've got a question that you'd like to ask, please click the Q&A function and ask your questions, and then others can also upvote certain questions so we know which direction to take this conversation in. But I will introduce the first speaker, who's Dr. Basani Baloyi, who works for Oxfam South Africa and is the inequality lead. Our second speaker would be Busi Sibeko, who's a researcher at the Institute for Economic Justice. They'll each give 10-minute inputs at the beginning. There'll be some short follow-up questions from myself, and then hopefully by then there'll be active discussion in the chat and in the Q&A, and I will lead the discussion from there. So Dr. Baloyi, if you could please kick us off. Could you put your video on for us, please?
Hi, everyone. Thank you so much for inviting me to this important discussion. I'm just gonna try and share my screen with you all, and then just make it to the start of this presentation. Okie dokes. So I am going to be, I'm going to be presenting findings from our research, which is the basis of a campaign called the Care for Carers campaign. I'm not sure if you can see my screen, but all those who are listed over here are part of the Care for Carers campaign. It's Oxfam South Africa, Young Nurses Indaba Trade Union, South African Federation of Trade Unions, NOKWASA, and Treatment Action Campaign. So what is important to bear in mind is that this report is not a Oxfam South Africa only report. It's actually one that was co-developed with Young Nurses Indaba Trade Union, where much of their experiences were workshopped, and then they were quite part in terms of the research development process. So unfortunately, we don't have Wainutu comrades here. Everybody's preparing for the general strike on Wednesday. So yeah, but that was very important to note. So I'd also like to stress that the report is not necessarily a report about the COVID crisis. It's about the health crisis, right? And in fact, the crisis of work, and how the crisis of work within the healthcare sector actually has a negative impact on the quality of healthcare. And so, however, much of the findings are very key to this moment. In fact, it reveals a lot of what the weaknesses are of this moment and going further. So, I mean, the key findings of the report is that, you know, we have a gender-blind austerity government and a chronic an underinvestment in the public healthcare sector, as well as the extractive nature of the private healthcare sector on the one end, and gaps in labor law and practice have combined to produce deteriorating working conditions for healthcare workers, community and nurses in particular, that results in a system that is really unprepared for COVID-19. Much has been said about the health budget, and I'm sure my colleague, comrade Busi will talk about that. And also there's been discussion around the private healthcare and how extractive it is and how for profit it puts profit before people. But much less has been said about what are the gaps in labor law and practice that actually have a negative impact on healthcare workers. So these are the three kind of like issues that we try and unpack in the report. So, so if I may, like, I'm gonna try and meet the 10 minute mark. So, you know, prior to the COVID-19, we had been witnessing reductions in our expenditures, budgets, right? Particularly within health over the last 8 years. And as a result of which, to meet the kind of targets that have been set by the DOH, which is a 60% target for compensation, there have been restrictions around filled posts, and those have been increasingly implemented across provinces. And basically what some call a de-skilling of supervision within the nursing and in a de-skilling of the profession that has affected nursing and CHWs, where certain higher grades of nurses are not being employed, but are actually being replaced by underqualified, if you may, nurses as a way of maintaining costs, right? And so between 2012 and 2016, half of the professional nurses were hired as compared to 2006 and 2012, right? So what this has done is that it has led to really a chronic under provision of healthcare workers, nurses, community healthcare workers. And they are just like inadequate staffing ratios. And this contradicts what some may call like, you know, a shortage of nurses. But actually what's happened is that there's been like a deliberate attempt to understaff the healthcare profession. Another area in which how the cuts have affected is that we are more and more not employing support staff right? Instead, nurses are then having, the nurses that we have in the system are then having to be the security guard, the cleaner, the admin support, and so they are having to take on various other tasks because of this shortage. And of course, then the wage freeze, basically, that has happened. Within the private, as this has happened in the private healthcare sector, from 2016 to 2019, the payouts to shareholders, so that's dividends and shareholder buybacks, by Netcare, Life Group, and Mediclinic have been larger at 19 billion than the profit made by these three companies combined at 11 billion. And you look at the company financial statements, what you realize is that some of these companies will be paying to shareholders even when they are actually making losses. So Netcare being one, paid out 1.3 billion to its shareholders in a year when it made about 493 million in losses. So over the 4-year period, the cash paid to shareholders increased by 96%. By 4 year, I mean between 2016 and 2019. And these shareholder payouts amount to an average of 92 million rand per week. And of course, we know that the private healthcare sector is subsidized through medical tax credit, through the state, through the fiscus, and 35.4 billion medical tax credits could actually be used for public healthcare, which would increase the budget to public healthcare by more than 60%. So you kind of have a private healthcare sector that is almost through these, and contributing as a result to our underinvestment in the public healthcare, I would say. So it's been very interesting as well, shocking, is that whilst these shareholders have continued to extract from through shareholder payouts, this has also happened at a time when there has been an increase in labor brokering of healthcare workers, right, nurses, within the sector. And so the cost containment and the cost cutting is happening through that means. And so it's a huge gain by shareholders overlap with basically deteriorating conditions for healthcare work. And so, I mean, healthcare work in South Africa and generally globally, it's a feminine sector insofar as it's predominantly women, in spite of the population different, like 90% women, but they have like 50% of the population is women. And representing 77% of our public healthcare sector, human resources, or health, nurses constitute basically the backbone of South Africa's national healthcare system. And in 2018, the number of women overall population was 51.2%, yet women made up 90% of nurses. And underpinning this whole system is this primary health system is a complicated network of healthcare workers who deliver essential health promotion and home-based care to marginalized communities. Okay. So yeah, that just basically explains that. So we have this chronic underinvestment, as well as this very extractive private healthcare sector. And so increasingly the deteriorating condition of community healthcare workers and nurses resulting in a system unprepared for COVID-19. So now I'm going to share how the various policy gaps within labor law have actually deepened the crisis within the healthcare sector. They combine. So the point is to say these two types of employers, those in the public and private healthcare sector, in addition to all that I've described, they also expose the gaps in labor law and practice to further exploit healthcare workers. So we're going to look at working hours, low pay, GBV, labor brokering, and universal healthcare. So in terms of work time, there are weak working time limitations, right? And those would be provided by the Basic Conditions Employment Act. And basically, you know, a worker would be guaranteed a certain number of hours, I think 40 hours, like an 8-hour day shift, and be compensated accordingly. So, however, what we find within this legislation is that for those who are the statutory protections for work time, so which allows for you to have kind of like some kind of a work-life balance, certain sectors or segments of are not protected from this. So you have senior managers and then employees that work 24 hours, less than 24 hours a month, and those that earn over the BCA threshold of 205 rand. And the problem here is that many nurses earn about 200,000 notch. Now, however, in what I've just described, which is this chronic staffing of the nursing profession, that is comes as a result of these cuts and freezes in filling of posts, and that's in the budget, right? What you have is then a lot of these health workers who earn above the threshold will obviously be protected in terms of their own work time, right? Especially because at the same time, the provisions say that emergency workers are all excluded, right? So because there is this staffing that has happened, this is a set more, and because of the nature of the work and the quadruple burden of care or disease that we have within our own health system, one of the countries with the most heavy disease burden globally, what you find is that healthcare workers are more susceptible to emergency work. And because that has been extended in terms of ensuring that they have work time protections, you find that healthcare workers are having to work extended hours, right? And so, and given that this is a sector that is predominantly women in the sector, they cannot have this, they have also the double burden of care. So not only are they having to take care of many people with the system, yet there's very limited numbers of them. And as I described, the cuts have also meant that they actually are taking up other tasks. And then on top of which don't have time for their own care work at home. So this has got a number of impacts on his healthcare workers are stressed because, as one healthcare worker says, that I added myself into because there is such a demand of time from just the number of people there, but it isn't enough of us to actually be responsive, right? And so this affects them in terms of stress. They've got mental health complications. They actually have risk of breast cancer because the extended number of hours of work, so a lot of the times, they don't actually take breaks, right? And then, of course, this affects your own job satisfaction and then the motivation of providing quality care. So it's quite important to look at these things because we all complain about, you know, the public healthcare system, the sisters are very like this and da 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 da. There are structural things like impossible.
Sorry. Just two things. If we can give you 2 more minutes to kind of wrap up, but also we're losing your sound a bit. Perhaps if you could switch off your video, maybe that'll help the bandwidth better. Yeah.
Okay. So in terms of, I'm gonna try and just wrap up. So in terms of public sector, okay, let me not get there. I can ask certain other things I can speak to in the thing. So this is also a sector that is increasingly becoming labor brokered, like the private sector being the most dominant sector that actually employs a lot of healthcare workers that are labor brokered. So what has happened here is that you have the LRA that basically says that if you have been employed through a labor brokering, after 3 months, then you will be permanently employed by a client. However, this is only for those who work, who earn below, from 205,000 Rand below. And as I said, there are many nurses that work, that earn above that. So they are susceptible to be permanently labor brokered. And of course, this affects the types of benefits that they get. They're not susceptible to pension, not even medical aid. So you have a lot of healthcare workers who are labor brokered within the private healthcare sector, and yet they don't have private healthcare. And in fact, we just did a survey that just reveals how many of them are out there that actually don't have even protection when they are, you know, treating COVID patients. They are not given free medical attention by their employers. They either have to do it via through their own medical aid, or sometimes, and for those who are in the public healthcare sector and some who are employed permanently within the private healthcare, that would be contributed, and then others who are who are labor brokered would not. And then over here, we also look at just the level of gender-based violence that healthcare workers face. As many women in South Africa do, they face gender-based violence. 69.4% of female nurses have been impacted by this, and 30% of them reporting they've been physically abused. And of course, this kind of the abuse that you face at home is also one that you are likely to kind of, I'm skipping, sorry, I don't quite know where I am at this moment, is one that you are is then when you meet the workplace, it's one that you are likely to just normalize in that sense because of the lack of safety that women in the country are actually provided in response to gender-based violence. So this, in terms of how this mostly affects healthcare workers, obviously, as I said, there is this tension between patients and healthcare workers as a result of the structural inadequacies within the system that then kind of like inform a conflict, right? That leave a lot of healthcare workers violated. Some have been raped, others have been beaten up. So there's that. And then on top of which, we also explore how the transport policy in the country through the BCEA, which basically says that employers are required to make transport available, right? However, there's a difference between availability and provided, right? To make transport provided for healthcare workers, especially those working in night shift, right? And that has always presented a tension in terms of their exposure to gender-based violence. And of course, for community healthcare workers as well, who are, who's like, again, the occupational health and safety, I think it is basically speaks about the place of work as a physical place, right? And that is what then it conceives of someone who is then compromised carrying out their duties, having to, will then be provided with some kind of like insurance, right? However, okay.
Yes,
So I will talk about it later then. Sorry about that.
Cool. All right. Thank you very much. I think we're trying to just make sure that there's some time for questions and clarifications. But I think Busi Sibeko, if you could also try to keep tight to about maybe 7 minutes, so we can make sure that we can, cover a few issues. Thank you. But as was posted in the chat, this report is also available on the Oxfam website, and that's been posted in the chat.
Okay, thank you. I'm also gonna share my screen. Hopefully I'll try to keep it at that. But yeah, thank you so much, Basani, for covering that. I think you've already covered some of the things that I was hoping you'd cover, so that I don't have to go through them again. But one thing I wanted to emphasize was that, or start with, is to say everything that Basani has said around what is happening in the healthcare sector is a result of the economic policies and the global status quo, so to speak, the mainstream economics that has been implemented globally. And what do I mean by this? Globally, we've had sort of an orthodoxy in economic policy making, which in many ways has actually relegated some of the public services, such as health, for instance, and left them to the private sector to pick up and provide. And so later on, I'll talk about how austerity, which I'll define, reinforces this. But to say we've come through a history of neoclassical economics, which really believes in sort of a small state. If I were to, minimize that whole definition that you can read there, but it's really about how do we create a small state and private sector provide majority of the services needed in the economy. And in fact, the best economies, according to this model, are ones where most goods, if not all goods, ideally it would be all goods, are provided through the private sector. And that's how employment is created. That's how the economy works. And, of course, we've all learned, or most of us know, about the invisible hand. And so in a way, the economy just functions by itself and corrects itself where it is wrong. And the prices are set right and so forth. And so, like Basani already mentioned, this doesn't necessarily work, especially when it comes to wages and so forth. How people broker wages and so forth is critical, because the neoclassical economics assumes that people's wages will be correct. And so what this has led to is neoliberalism, and neoliberalism is really about the policies, right? So neoclassical economics is, like a school of thought, but the neoliberalism borrows from neoclassical and therefore creates certain policies in the economy. And so because of neoclassical economics, we've moved from a state-led to a market-led, like I've already defined, sort of economies. And through time in South Africa, through the GEAR framework, through most of the economic policies we've had, the focus has been on stabilization, liberalizing markets, particularly labor markets, privatization and rationalization. And so, privatization around Eskom. There was big movements in South Africa in the 90s where there was an attempt to privatize a lot of SOEs that still exist today, and we're probably going to see this rise again. And so the issue here is really, like, as we said, the key assumptions about macroeconomics are really about aggregates and all these things that I've already mentioned. But another thing is that they're generally gender and climate neutral. Basani already started talking about how women working in health, for instance, have to do this care work, which is paid for in their jobs, and also how they have to go home and do unpaid care work, which is to take care of their families in the households. And so with the high burdens of disease in South Africa, it means that women predominantly are the ones who undertake a lot of that care work that happens at the households. But what is important that we need to know is that macroeconomic policies are not neutral, despite how they've been put forward in the past, and that different groups across have different impacts, distributional impacts, and which is why we have to be critical about the gendered nature and the intersectional nature of economic policies that in fact impact some people more than others, right? 90% of women in the, in the healthcare sector, as Basani's already said, are women. So it is critical that we talk about the gendered nature of work. And so, of course, neoclassical economics assumes Robinson Crusoe, who's a man, rational, self-interested, independent, has no responsibilities. There are no environmental considerations about, if they use these resources to get labor, what happens to the climate, what happens to the environment. And really, it has this separation between what is produced in the market, productive labor, versus what is considered reproductive labor in the household, and that is generally ignored. So there's reproductive work in the household, but macroeconomic policy or economics does not acknowledge this because it assumes a full-grown human who's ready to enter into the workforce. And so where we are in the current moment in South Africa is one of austerity, and austerity means it is fiscal policy implemented by the state to solve debt and growth problems during a period of weak economic growth. And this is critical because you can consolidate your finances when your economy is growing, and that is not austerity. But if you're cutting your budgets when you're in a period of low growth, then that's austerity. And so this is definitely not just a technical process, but rather a political process. So we're in a political moment where we've chosen austerity. But the things about austerity is that it actually reinforces the neoliberal model, which again, as we've said, is gender blind, is environmentally blind, ignores, household work and so forth. And so austerity legitimizes this desire to have a small state, right? So in countries where they've implemented austerity, they usually cut, like Basani's already mentioned, they freeze posts, they cut wages, they basically reduce the state's responsibility. Actually, that's what happens, and it's all because of debt. And so I won't go too much into this, but to give two examples, which Basani's already started seeing or already started talking about. So in health in South Africa, we've seen that the budget for health has increased, yes, by 1.7% between 2014-15 and 2018-19. But the problem is that 1.7% growth is lower than medical price inflation, for instance. So what you're seeing is that there's a per capita decline in spend for health. And so although the absolute number is increasing, but how much we're spending per person is actually been decreasing over time. And that's what austerity does, right? It's about cutting, and there's critical staff shortages, Basani's already spoken about. There's also been an increase in medical legal claims, which of course we can correlate to poor service or poor provisioning in some instances. And of course, the national health insurance has been delayed. But in health, in education, we see similar trends, and there's been decline in expenditure per child over time. And Nick Ball said that it was 10% between 2010 and 2018-19. I think he's reconfigured those numbers, and so it's probably higher now. Class sizes are increasing. Poor schools with infrastructure backlogs don't have funds, and their funds are being taken away, which is why we still have schools with pit latrines and so forth. But what do we know about austerity is that there are, it doesn't lead to less debt. In fact, in most countries, it's led to an increase in debt as a share of GDP. It's it's led to increasing unemployment, it's led to a decline of social protection and a decline in the provisioning of public services generally. But these impacts have been gendered. So unemployment increases, I mean, we'll see in South Africa soon enough, but globally what has happened in the first sense is that men lost their jobs before the financial crisis of 2008, and then women lost their jobs because of austerity. But in South Africa, I'm not sure what this trend will be. It might not be the global one, because as we've seen through the COVID crisis, most of the people who lost their jobs have actually been women. So curious to see what will happen there. And so because of all these different things that have happened, unemployment, social protection lack, women have really had the hardest impacts, and vulnerable groups, minorities, people with disabilities and so forth are the ones who are really bearing the burden of austerity, and that is critical to know. So South Africa really needs a feminist fiscal policy, and what we mean by that is really to say how we spend today can literally change our economy in the future. And so we need to move away from the way that we're thinking of fiscal policy right now, which is one of austerity, and we need to spend in the ways that will lead to a different future for South Africa. And so what we mean by this, for example, is that we need to spend where there's the highest impact. We need to spend on households, which is why a universal basic income grant is critical for demand, to boost demand in our economy currently, but also it leads to some development in the domestic economy, because poor households spend majority of their money on domestic goods. So it is critical that we boost demand in those ways and develop our local economy. We need to spend, for instance, on the care economy, and I'll just jump around these to give examples of why a feminist economic policies are critical. But we need to spend on the care economy because, as data has shown, or some examples have shown, is that it actually creates jobs. Not only does it build physical infrastructure, which is critical and already a part of what government wants to do, but what it does as well is that it's actually beneficial for women. It increases employment for women and men, of course, and this is not to exclude men, but to say investing in the care economy, which is not a traditional sector that's been invested in, will change our economy, because when you invest in the care economy, one, more women are also able to participate in the economy and so forth. So there's many other economic multiplier effects from just investing in the care economy. We need to invest in green technologies and investments generally to change our economy. And so these are some of the things, and I won't go through all of them given that we don't have much time, but to say that it is critical that we all rally around feminist fiscal policy, which goes beyond what is currently happening, but looks at how do we change our economy in a way that is equitable and is gendered and is climate aware, and that is critical moment where we are. And I know everyone's got this burning question around structural reform. Why don't we just implement structural reform and that will make this South Africa better? But let me start by saying the structural reform is sort of what we've been doing since 1994. And it is critical to acknowledge that when we say we want structural reform, we are saying that the status quo is sufficient and we just need to do it better. And my argument would be that the macroeconomic policy framework itself is not sufficient to get South Africa to where we need to be. And so it is also important to acknowledge that macroeconomic policy in South Africa has really been focused a lot on the demand side. How do we build infrastructure? How do we, so forth? And it is important. And so what I want to say here is that structural reform and structural transformation need to be considered in a particular way. Structural reforms can be a part of policies that we want for structural transformation. Infrastructure expenditure is critical for structural transformation, but what we are saying is that we want infrastructure expenditure, for instance, in the care economy, which is different. It leads to a particular type of structural transformation, but also just increase in expenditure is critical in those areas that we're talking about. And so we need to rethink our macroeconomic policies generally, and we need to pro-employment macroeconomic policy framework, and that we need to stop this dichotomizing of structural reform versus, other policies, I suppose, but to really say that how do we think about structural reforms, but also fiscal stimulus, which would not be considered in the current status quo to change the structure of our economy overall, and that the current structural reforms are not sufficient for South Africa to get there. That's all. Thanks.
Fantastic. I was just climbing on to about to censor you, but you've done well. Thank you very much, Busi. I think we'll keep going, and I'll just ask one follow-up question to Basani, and then also one to you, Busi, and then we'll work down questions that have come up in the chat. So Basani, I'd like to give you perhaps an opportunity, maybe over 3 minutes, to mention anything that was a burning issue in your presentation, but also to give us a sense of the Care for Carers campaign, just to get us to think a bit about the action that is happening and some of the action that is required. So just to give you those 3 minutes for you to return, and then we'll see. I'd just like you to, again, after Basani has given her comments, if you could perhaps also just say a bit more about maybe in the upcoming budget, what you expect will happen in the future with regards to the funding of healthcare post COVID-19. So Basani.
Thank you very much. I think what I will do is just kind of like talk about the recommendations that we have from the report itself. So basically, Busi was talking about a caring economy, or the care economy. So we see this. What would be key is that we need to see an increase in government spending on healthcare. This is critical to get the kind of risk, because we have suffered from a structurally dysfunctional healthcare system even prior to COVID happening. And what we see as government trying to manage this by just employing people on a short-term contract basis to meet the current critical demands, as it not sufficing to actually deal with the structural issues around our chronic understaffing. And of course, this is important because we need to ensure that we are not relying on because we're going to have a second wave, and it's quite crucial that we are not just relying on and currently we are paying these private healthcare providers 16,000 Rand per day per patient in the ICUs, right? So that is going to be crucial, that we actually develop the capacities within our own public healthcare sector. But crucial to this is that we have universal healthcare, right? That being very, very important. And the way in which the current NHI is being devised is one where private healthcare companies will continue to benefit from it. We basically want to ensure that they are not part of it, and we have a true universal healthcare coverage, because they will continue to make money, and then we'll continue with their cost-cutting mechanisms as we've seen currently. But most importantly, this actually has a big impact on the quality of care that is then delivered. Because as you know, I just spoke to you about how we are currently almost subsidizing the private healthcare sector through our medical tax credits. And this, and how that could have actually provided or added to 60% of the healthcare budget. And then what you have is this unequal distribution of resources that is deeply faced by those public healthcare sector workers who have a shortage of medication, a shortage of PPEs, a shortage of everything, beds, all of it, right? And so they then are unable to provide the quality of healthcare that is needed. And then you have issues that happen in Tembisa Clinic as a result of that kind of tension. And so to see the private healthcare sector as something that is extractive and that is actually contributing to under-provisioning. So it's not just a public healthcare issue, but it's the way in which our system has been built becomes very crucial. And then creating the conditions for decent work and work towards a living wage. This is very crucial for community healthcare workers who are still chronically paid, right? And then, of course, with the occupational, the OSD dispensation, that has not been resolved, right? So nurses have not actually had their increased increments because of the 60% wage cap that they face. Important to secure contracts, right? So the end of labor brokering. I see in one of your, there's a question around what exactly is labor brokering. Well, that is basically agency work, recruitment through some kind of an agent that is employed by the actual employer, the client. And so that they become like a third party recruiter. And they tend to, especially those who are in the NGO and also those who employ, in the private sector that use agency workers, the recruiters, if you want to say, call them that, they end up actually taking up quite a lot of what should be due to the healthcare worker or profession, right? And this creates, as I said, insecurity for, because if you earn above a particular threshold, then you are not subject to the same terms as those who would have been employed over 3 months and then can be permanently employed. However, what we are also finding with health within the sector is that even if you are if you earn below that amount of money, what you're finding are people, you are never given guaranteed working hours such that you will be so that you can actually say you've made up the 3-month work time, right? As a way of consistently keeping you insecure. So the improvements to the labor law have not actually resulted in employers basically stopping this practice. So we are actually calling for a banning of this, and the Namibia case in terms of how their legislation has been set up to say, okay, we will have labor brokers, but then you are permanently employed from day one. So they're just there to fulfill the identifying of workers and placing them, like a placing mechanism, rather than a quasi kind of employer. And then to recognize the burden of unpaid care work, because many healthcare workers do not actually have, like they're not healthcare facilities or care facilities for children at healthcare facilities. And basically, as I said, there's this double burden of care that healthcare workers suffer from within a space that is chronically understaffed as well. And so to ensure that their children or households are also taken care of, this will be very crucial. And then reducing the inhumane working hours for healthcare workers who are having to work extended hours. There are provisions within the ILO that kind of like create a statute that is specifically for them. But obviously all of this is linked to ensuring that we have enough healthcare workers there so that it can reduce the amount of time that they spend on work. But crucially, they need to also be protected by labor legislation. And currently the labor legislation is not protective of these healthcare workers. Those are some of the issues. Now, the Care for Carers campaign, very crucial. We've got a petition that is out that is basically saying we need to call for a stop to shareholder payouts over the next 2 years between now and 2022 for these private healthcare companies, Netcare, Life, and Mediclinic, and use those available resources for the provision of PPEs, regular, adequate PPEs, medical attention and regular testing for all healthcare workers. So not just their employees, but for all healthcare workers. Because this is going to be with us for quite some time, and we need to make all resources available. So we are basically calling for the private healthcare sector to be a team player within this crisis. So it's not just the public healthcare sector, or government, but the private healthcare sector also needs to be a team player. They cannot profit from this, and we are calling for an end to or a stop of shareholder payouts, basically. There is going to be discussions for very soon in terms of whether they pay or not, and we want to create public pressure around that. And I will pop the petition that for everybody to sign in, and then to just pass it along to others as well. Thanks. That's that for me.
Thank you very much, Basani. I think as part of your closing wrap up, could you please also, say, if you can, a bit more about that campaign and the others that you're working with, so we also have a sense of them. But then, Busi, could you, for about 3 minutes, sort of also answer that question in a forward-looking way about the health budget? What are next steps? What are things that can be done? Thank you.
Was it Basani first?
So no, so I was just pre-warning Basani for her closing remarks, but
oh, okay. I was like, I think Basani's the ones. Okay, so I think critically for the MTBPS, we know that there'll be the status quo. So if you look at, for instance, what the budget was, the MTBPS, the medium-term budget policy statement. I always mix up the words for that one, but to say that when you look at it from the 2019 one and you actually look at the supplementary budget, you realize that a status quo is being maintained. How they plan to cut the budget then, the amounts are still the same. The difference is that the composition of the budget itself has changed, but the austerity measures that were proposed are still ongoing. So I think it is critical to understand that the logic of austerity has seeped itself into our COVID response, but on top of that is that it's going to be ongoing forward, because remember that the medium-term expenditure framework last year indicated that the budget would be cut by 5%, 6%, and 7% over the next 3 years. So critically, what my expectation is from this current administration is that that intended austerity will still take place despite what is happening in our economy, and despite of what's happening in terms of just the sheer destitution that's happening in our country right now. So that's the one thing to say. And I think critically in the MTBPS, what we'll see is this notions again that there's no alternative, that this is the only way that we can move forward. And so it will be the same old in a way. Before the supplementary budget, Tito Mboweni already said that we're no longer as rich as we were before. And in fact, COVID will just re-emphasize that more for them, right? COVID is going to be a way to justify why austerity needs to be undertaken. And of course, given I acknowledge that our revenue has dropped and that our tax is going to be affected, but it doesn't mean that this is sufficient to say why we should continue on with austerity. In fact, it's calling for the opposite. It means we must do more. We must actually change the way that we spend and do more to save our economy, as opposed to shrinking expenditure and actually making things worse. I think critically we need to question, what is the role of fiscal policy in a social democracy? That is really the question. What is National Treasury's role? What should they be doing? How do they see themselves as a key player in changing the structure of our economy? And in fact, to really go back to say neoliberal policies are actually not to build a social democracy. That's the bottom line. Like, the current policies we have are not going to build a social democracy, and it's 26 years in, and we can already see that this is not what's happening. So it is critical that we change how we think about it and review how we think about fiscal policy. I think lastly, it is critical. So the first one is that we need to spend on universal basic services. That is the most critical. We must protect universal basic services, and we must provision sufficient social protection in South Africa currently. Those are the things that I would say most critical on the table for the MTBPS that must happen. I don't know to what extent they'll happen. For instance, will they introduce a universal basic income grant? Will they continue with the current measures that they have to protect households? I don't know, but those are going to be critical. And I know that there's resistance to do that. So that's very worrying. And the last one is to say, structural transformation is also about challenging power from an intersectional level. And so we're not just talking about structural transformation as in, our economy is diversified. We must think about structural transformation that also challenges power ultimately in that composition of diversification, if you want to put it that way. So that's my my last words around what I would have added and what I think what's going to happen in the MTBPS.
Cool. Thank you very much. Perhaps I will give Basani the last word in the last minute that we have, especially in terms of how people get involved, how they contact you, and then perhaps you can wrap up the conversation.
Thank you so much, Bandile. Just to say that, you know, the demand that I've just spoken about is not a demand by Oxfam, but it's actually a demand by the allies that we work with, the Young Nurses Indaba Trade Union and National Union of Public Services and Allied Workers and National Union of Care Workers of South Africa, SAFTU, being their federation, and then the Treatment Action Campaign as well. So we are working within an alliance. Now, there is a petition. It's a digital petition. I will drop it in this chat box. And basically, please, that would be the key action. If you can just sign up to that petition. As I said, it's about pausing the shareholder payouts and making those things available, right? Number one. Number two, if you could please, just put up a placard and basically write "Care for Carers," right? As you sign this petition, and put it on your social media and tag us, right? Oxfam South Africa and Young Nurses Indaba Trade Union, and all our partners as well. If you can tag us onto that post, that basically creates a lot of visibility. And also tag these guys as well, Netcare, Life Group, and Mediclinic as well. That would be, if you could do those two actions, that will be very crucial. So what I'm going to do is that I am going to send the petition to Ubandile and his colleagues, and I'm certain that he has your contacts, and then you can basically sign up to that, and if you can, as I said, a placard saying "Care for Carers" and tagging yourselves and us would be great. Thank you.
Thank you very much. And I'd really like to thank our panelists, Dr. Basani Baloyi, who's the Inequality Program Lead at Oxfam South Africa, as well as Busi Sibeko, who's research at the Institute for Economic Justice, for their comments. I think these webinars are always very short, so I think it would be nice to maybe continue conversations on social media. And I also like to remind you that we have posted that link to the chat. There's a very nice web page that Oxfam South Africa has put together. It's got links to the report, it's got links to a short video, and I think in addition to what Basani has given as our call to action to actually follow up on that. So we can also email,
Just to say, Bandile, sorry to intervene there, as you were saying, the petition itself is actually on amandla.mobi, so I am going to provide that for you, yeah?
Okay, cool, great, and we'll get it in the inboxes. But thank you very much. Right. Everybody be safe. There's now the first rains in Johannesburg, and so we'd urge everyone to travel safely and be safe, and stay in touch with everybody for future discussions.
Thank you all. Thank you. Bye.
Bye, everyone.